Good morning from Brazil all. We are today in our first Rural Family Medicine Café with a great team from all around the world. We have students from Tunisia, we have students from Brazil, from UK, and hopefully we have some more people sooner. So today we have a very special theme, that is what is family medicine, and we will try to discuss together and find a common agreement of what is family medicine and try to elucidate some doubts and understand together what is the concept and what a family doctor does or a general practitioner. And I'm really happy to be here today. We have the students from Univates watching it in Brazil. So hi guys. Please send your doubts and things on the Rural Café page. And on Facebook, we have Karine and Bianca coordinating, or with the hashtag Rural Café on Twitter. So start, I will introduce myself first, and then I will ask for each of the participants to introduce themselves. So my name is Mara Floss. I'm a medical student from Brazil, just finishing my medicine studies, and hopefully a young doctor in a few weeks. I'm really excited. I'm also coordinating the Rural Seeds, and I was one of the creators of the Rural Café. So may I ask to Amber to introduce herself?
Hello everyone, my name is Amber. I'm originally from the Virgin Islands in the Caribbean. Now completing my studies as well in Swansea. I'll be done in a few weeks. And I've always had an interest in rural medicine. I'm part of the Rural and Remote Health and Medical Education track at Swansea, and I will be starting my foundation program at a semi-rural hospital in Smethley in a few weeks' time. I'm very happy to join this topic, especially because it's such a hotly debated question. What is family medicine? So thank you all for having me, and I look forward to our conversation.
Bianca?
Hello everyone. Good morning here in Brazil. I don't know what time is it in around the world, but well, I'm really happy to be here. I think that this theme is absolutely interesting and huge, and we can talk all day long about it. And I'm Bianca. I should introduce myself better. Sorry. My name is Bianca. I am in my 5th year of medical graduation here in Rio Grande do Sul, that is in the south of Brazil. And I absolutely love family medicine since my 1st year. I'm happy to be here, and that's it.
Karine? Karine, you just need to mute yourself. Yeah.
It's okay? Yeah. Okay. Hello, everyone. My name is Karine Pous. I'm from Brazil, from the same university from Bianca. I think it's very important to discuss about what is family medicine, because I know family medicine in the beginning of my course, but I just really understand family medicine I think in the last year. I'm now in my last year of graduation. I will finish in December, and now I really love family medicine, and I think it is very important that we share this experience with another students and talk more about this here in Brazil. I think a lot of students don't know how works family medicine.
Nadir?
So hi everyone, I'm Nadir. I'm from Tunisia, a medical student. I just finished medical studies yesterday, so I'm waiting to begin my internship in next year. The concept of family medicine is new in my country, so I'm looking forward to know more about it and welcome to it. Thank you.
Yeah. Nishwa?
Hi everyone, I'm Nishwa and I'm a fourth year medical student from Pakistan, and I'm very passionate, which made me realize the importance of rural health, etc. But family medicine is interestingly that was introduced to me by Mayara about a month back in Tunisia. So, but since then I've come back and searched a lot on the issue, and it's just making me realize the importance of it. So I'm really excited to be here.
Cyrene?
Hello everyone. Hi, my name is Celine. I'm a fifth year medical student. Well, I just finished my medical studies, and I'm here to know more about family medicine since I will be taking an exam to choose my specialty. So I want to know more about that issue. Hi.
Safe? Safe, you are muted.
Hello.
You...
Hello. Do you hear me?
Hello. Hello.
Hello.
Hello.
Hello. Well, hello. I'm Saif, fourth year medical student from Tunis. And I'm sorry, Mayara, I'm sorry everyone for being late. Can I have the questions that I need to answer for here?
Oh, don't worry, Safe. You just need to introduce yourself and maybe say what you're expecting for the cafe today, and then we will move around on the topic. Don't worry. There is no formal question.
Okay, so sorry again. I'm Said, fourth year medical student from Tunis, and I'm here to discover the rural cafe to improve my knowledge about the family medicine and family medicine concepts around the world, so that we can put in Tunisia a kind of solid family medicine system here, because I think that we really need it. Hello.
Great. And Ewing just arrived. Can you introduce yourself, Ewing?
Hi, I hope you can hear me. It's very late in Australia. I'm a rural GP in Australia. I'm president of the Rural Doctors Association here, and just getting home from the annual Rural Doctors Conference, so it's been a good day.
Great, and we just have Jess now.
Hey, can anyone
Can you
hear me?
introduce yourself, Jess? Yeah.
Okay, I'm Jesse Rodmore. I am from the United States. I'm a fourth year medical student. Also in charge of the student constituency group with the National Rural Health Association. And kind of met Dr. Wynne Jones back about a month ago. And so really encouraged us to be involved in these. I've done a couple of these, I guess, last year. So I'll be finishing up my last year of medical school this upcoming year. So glad to be a part.
Great. So now that everybody have present yourselves, we can start about what is family medicine. So anyone wants to think about what is family medicine? I think Misha have a very funny a story that she asked what is family medicine in her universe, and she got a really good answer. So do you want to start, Nisha, about
Yeah, sure.
your experience, and maybe like we can start from that?
Yes, definitely. So basically, family medicine is not a concept that is actually being practiced or even taught specifically in Pakistan. We are going a lot towards specializing, but not in family medicine. So it was a relatively new concept. So after MMAR, I came back and we had public health sessions that I was facilitating at our National General Assembly through an organization called IFMSA. So basically, in discuss sessions, I asked everyone what family medicine is, and it's unfortunate that no one knew about it. And then we had this guy jokingly raise his hand, and he said, "Oh, I know what family medicine is. It's the medicine that the whole family eats, like paracetamol or Desperate." So that was their understanding of family medicine, which was funny, but at the same time a bit sad. But it was really funny.
Any others have any experience to share on what is family medicine, and maybe a perspective from Tunisia as well? Who wants to talk?
Well,
Yes.
family medicine is here known as general medicine. We are making like a restructuring of medical studies during this year in Tunisia, and we are introducing now the concept of family medicine and some other new concepts to develop and to improve some specialties and the I don't know what's called, think working medicine or something like that. Well, in this new structure, the patients and anyone should go through a family doctor before going to a specialist. So the family doctors need to be like, we'll say, the first line of doctors of healthcare system, and then to move to the second line. So this the family medicine would be able, like in the perfect world, to solve most of the problems of the whole population, let's say.
Great. Jess, can you? Yeah, you can go, Bianca. That's okay. Yeah, perfect.
Okay. Well, I would like to say that I spent 1 year in the UK, and please, Amber, correct me if I say something wrong. But when I was there, I met a doctor. She was doing her residency in family medicine, and she was explaining to me that everyone who graduates in medicine in the UK, they cannot just practice without a residency or a specialty. I don't know how to say. And I would like to say to people that maybe don't know that here in Brazil, all the medical graduations in our country, they take 6 years, and after you finish your medical course, you may work as a doctor in lots of places. You can work in an emergency without a residency in emergency. You can work in a health unit without a residency in family medicine. So after you are graduated, after these 6 years, we say that you are like a general clinician. I don't know how I could translate it. So when we try to explain to people in Brazil what is family doctor, they confuse it. And we say, no, it's a residency. You are becoming a family doctor. This is different from when you are just graduated without any specialization. So here in Brazil, we have around 30 years of this specialty, and a lot of people still don't know exactly what is it. So I think that this theme for us in Brazil is really important because we have to talk about it. And I'm really happy that people in Univates, you are listening to us. I hope you are understanding. Please send your questions on Facebook or Twitter, any whatever, anywhere, wherever you prefer. But I think that it's like it's our job to explain to people in Brazil, and also your family, your neighbors, your friends. We need to explain what is the difference, because here in Brazil people make this confusion.
Maybe Jess, can you bring a perspective from US?
Sure. So, family medicine in the United States has kind of been around as a specialty for about 40 years. Before that, they were called general practitioners. That's an outdated term in the United States, and actually a term that family physicians don't like to be called. So if you call someone a general practitioner here in the US, they would prefer to be called a family physician. It used to be that you would do a 1-year internship after 4 years of medical school, and that would make you a GP. Well, they started to see that decline, so they created the specialty of family medicine, where you have to meet competencies in pediatrics and adult health and women's health, including obstetrics. The current state of family medicine in the United States is kind of interesting. We have developed what we call mid-level providers, such as nurse practitioners and physician assistants, and in most of the 50 states in the United States are passing laws to where these kind of mini physicians without the oversight of a physician. So our system is starting to make family physicians unnecessary and expensive, almost like they're the person in between having a mid-level provider and then getting to your specialist. The sad part about family practice in the United States is we have to talk about it in two domains. You have to talk about it in the theoretical and the practical. So in theory, family physicians are trained to treat a wide range of and age groups and both men and women and children. And then when they leave their education, then they go into practice, and that's where they actually don't use a lot of what they were educated with, mainly because of how our medical system is set up here, based off of money, and insurance companies dictate what family physicians can and cannot do. So while you may be trained in obstetrics, you may not be allowed to do that based off of where you're practicing, the hospital you're with, your insurance providers and carriers, as well as the insurance that your patient has. So I come from a rural area in the United States, and it's very difficult for family physicians to actually be a full-fledged family physician. Most of the time, they end up operating like an internal medicine, what we would call an internal medicine, where they just treat adults.
Great, thank you so much, Jess. Can we have a perspective from Ewing? I think they are a little bit less restricted in Australia about being called as a general practitioner.
Thank you. I just want to check you can hear me okay. I've just changed my headphones. Great. Yeah, look, Australia has a generalist model of care. So the patients, people, communities are looked after by general practitioners. We haven't moved to the terminology of family medicine practitioner, so we call GPs. GPs can have advanced scope of practice, so they can be obstetricians, they can be surgeons, they can be anaesthetists, they can be Indigenous health specialists, population medicine specialists, mental health specialists as well. Particularly in rural areas, so country areas where GPs largely look after everybody, and specialists are very rare in the country. Australia is one of the most distributed communities and societies in the world. If I could tell you about my town, I'm the practice principal. I've been in the town for 28 years. I'm a GP obstetrician. So I deliver babies, also cesarean sections, procedures. I am in charge of a practice with 12 doctors, and I have a local hospital with, which is also run by GPs. And there's 5 GP obstetricians in the hospital, all young women, 4 GP anaesthetists, a combination of young women, young men, and a GP surgeon who does a lot of the operations a specialist surgeon would do, but not all of them. So we can look after most of our patients from a chronic disease, primary care, preventative medicine, through to advanced obstetrics, anesthetics, and surgical skills in the community. But we're 1,000 kilometres away from the nearest tertiary hospital. We're 300 kilometres away from the nearest secondary hospital. We rely on aerial transfer and aerial retrieval if we need to send someone. So we have the Flying Doctor Service, which essentially is twin-engined aircraft who would pick up and retrieve a patient if we needed to send somebody. And again, by and large, the doctors who fly in the retrieval aircraft are GPs as well. So general practitioners are very much the core of medicine in Australia. There are many reasons for that. Part of it is the cost. GPs are the gatekeepers in the system. So you can't go and see a specialist without seeing a GP first. And because of our extended scope of practice, we often can look after many problems and not need a specialist. There's always that tension in Australia, though, that specialists, as we train more doctors, they want to become specialists because they earn more money. And the tension is that the country can't afford many, many specialists. So, but for me, a GP and a family medicine specialist is someone who looks after your family and your community from cradle to grave. So I've lived in my community for 28 years. My children were born in my community. They both left and gone to university and subsequently into other study. I've delivered babies of babies now. And I also educate the next generation of GPs. So a very different model from other countries. And we're general practice. There's some 40,000 GPs in Australia. There's 30,000 specialists in Australia for a population of around 23 million people. So that's a bit of a picture of what it's like in Australia.
Amber, can you bring your input from half Caribbean and half UK?
Yeah, sure. The UK has a very similar setup to Australia. We don't have as many GPs with other specialties in Wales where I'm at, but we do also have the helicopter retrieval, which tends to be anesthetics trainees rather than GP specialists with anesthetics. But the GP is very much sort of the gatekeeper, as was said, to the hospital. And most recently, they're trying to save money by making more services available in the community. And therefore, the GP is becoming more of an emergency specialist, pre-hospital care specialist, rather than just the gatekeeper. So what they've recently started in Wales is something called an ACT team, which is sort of a rapid assessment for people in the community, and then the GP decides whether or not they need further treatment within a hospital. So what happens is they would get a call, they would go visit someone's house with sort of the basic equipment that you would have for a pre-hospital emergency, assess the patient, and then decide whether or not they can manage them in the community or they need to go into hospital. And then we have our normal setup of GP clinics. We still do home visits in Wales or our house calls if the patient requires it, but it is very much managing chronic conditions. Very rarely you get something acute because we have a GP out of hours service, which is based in hospital. So a GP sees the patient, but it's in hospital. Occasionally you get one that comes to the GP surgery, but it's very much trying to decide what warrants going to hospital and what doesn't. Because the healthcare service in Wales is free, It's more managing supply and demand rather than anything else. So, you know, everyone who feels that their situation is emergency can go to the A&E, but it's sort of the GP's decision of what is an emergency and what isn't. In the Caribbean, so in the Virgin Islands, we have one hospital within 4 populated islands. The role of the GP on the island that does not have the hospital is to decide what needs an emergency transport and what doesn't. They're a little bit more equipped because the clinic, for example, on the island I live on, the clinic there is also an emergency center. So any immediate trauma or any emergencies will always be managed there first. We stabilize the patient as best we can and then get them over to the hospital. The GP in the capital where the hospital is it acts the same as in the UK. They're sort of the people who decide what needs to go to A&E and what doesn't. They have a little bit more, a little bit less stress because they know that the hospital will always be open 24/7. There will always be someone there. Whereas on the other islands, it's sort of like, you know, you have a very tiny window. You know, you're basically Monday to Friday, 9 to 5, and you have to act, or else the patient will not be able to be seen. And there are a few islands where there isn't a doctor base, so the clinic is run by nurses, and they have to do the call of whether or not the patient needs emergency transport, which can be a bit, you know, it's very stressful, especially, obviously those islands aren't very well populated, but if you only have 2 nurses running a clinic looking after a population of 200, and you have some obstetric emergency that goes horribly wrong, you know, it can be a bit tragic. But yeah, so for me, family medicine, the way I would describe it is sort of the gap between the community and the hospital, which, you know, depending on where you are, what is within that gap can cover a wide range of things. But in Wales, it's sort of the not quite emergency, and in the Caribbean, it's very much, you know, depending on getting the patient to the right place at the right time.
Great, thank you, Amber. Thank you all. We just had John is just arriving. I think he's getting his phone. Bianca Liv, she's watching and accompanying on Facebook and Twitter, so John could enter on the call, and she will bring her inputs to Karine and myself, and then we will bring to the call anyway. I will just ask, John, can you introduce yourself and talk in your perspective what's family medicine?
Right, can you hear me okay? Great. I'm ever so sorry I'm late, but I've just been to see my new granddaughter, who was born 2 days ago. And so it's one of those special occasions where you see a new life coming into the world, and I'm very, very pleased grandfather. Yeah, look, I'm a rural GP in Wales. I was a rural GP in Wales. I still teach at medical school, but I don't do any clinical work anymore. And I finished that a year ago. But I worked in the same practice for over 30 years. I retired, missed the job, so I went back and I worked in an even smaller little practice for 4.5 years as a part-time, and I loved that. That was just wonderful. I've had a great career. I've thoroughly enjoyed it. For those who don't know me, I'm the chair of the Wonka Working Party on Rural Practice. And what is family medicine? I think family medicine is something in the UK that we're losing very quickly. It's something that is a really important investment that governments have to make in the quality of healthcare. It's unmeasurable to a certain extent because it's about people rather than figures. It's about it's about the quality of care that people have. Interestingly, at the moment, one of my best friends is dying of pancreatic cancer, and I'm being able to see family medicine from the other side, and that's been quite a surprise to me. How you know, there are certainly the practice that he's in. I'm really distressed at the level of care that he's getting. I think family medicine is about looking after people from the cradle to the grave, and like seeing my granddaughter being born, and also seeing my great friends out of this world. So, and it's everything in between. I think we must be careful, though, that we are not after motherhood and apple pie, because you can't get all that. But it is about setting the standards that you want to have as a human being. And it's using those standards and those values to care for your community. So it's so big, I can't even start to describe it, but it's something that has been a really important part of my life. And I'm a lucky guy to have done it, really.
Thank you, Joe. Now I think we have the perspectives. I don't know if Sareen, Nadir, you didn't talk, if you want to tell anything. You're okay? Do you want to talk, or are you okay? Yeah, okay, go ahead.
So okay, basically family medicine in our country is if you didn't succeed to have like a specialty, it's your family medicine for you. So we want to like to know more about family medicine, to know what is supposed to a doctor in family medicine, what is he is supposed to do, like what is the line between a specialist and a family doctor, when we can say no, you stop, this is this is a family doctor can do, and this is not and this is a specialty thing. That's it.
Great. Nadir, do you want to tell anything so we can pack the two things before?
I want to add to what Celine said and what Bianca said, that people don't know the difference between family medicine as a specialty and general medicine. So, but in Tunisia, the concept of family medicine is new, that even family medicine residents don't know what to do in hospital. So, so we have to be informed, and our state must create the mechanisms to train better the residents in family medicine, and to let them know more of their role in hospital. Thank you.
Okay, so we have Nisha and Saif that want to add something, and then we move to answering all these questions. Okay. So Nisha.
Yep. Yeah. So I think the situation of the healthcare structure is very similar in Pakistan. Is like sort of similar to Brazil. And the term that everyone's using, like general physician for a family medicine doctor, we use the term general physician for someone who just completed med school. So if you've done 5 years of your med school here, you're automatically a general practitioner or a medical officer. So these are the terms that are being used. But if you ever try to tell anyone that, like, you know, what family medicine is, number one, you have the very similar issue that people would not know the difference, including myself probably a month ago, to be very honest. And then the other thing is, if you talk about rural healthcare, in Pakistan, there's a very big issue of human resources, in a way that there are a lot of other factors that influence someone who wants to either take a job or not in the rural healthcare settings. So we already do not even have, unfortunately, people or general practitioners who just completed their med school who would want to go to the rural health areas. So introducing a concept of family medicine as someone, like, you know, who would work, especially in rural healthcare health areas as well, which would require specialization, is something that is met with resistance, and most people think it's not practical. So I think in Pakistan, we need to go back to the basis of its importance in the healthcare system, but we're not taught that, and we do not really know about it to the least.
Safe.
Well, to talk about just to fulfill what Nadir and Thierry were saying. Well, we have a GP system that we've been using from dozens of years. The problem that Nadir and Thierry were talking about are mainly because we are applying a system that we haven't set some kind of strong basis to this system or to these programs. Well, we have some family medicine residents that are now in their clerkships and that don't do exactly what to do. So we are like here in Tunisia, we are like brainstorming about the family medicine system, but we have in parallel a kind of GP or general practitioner system that is going, and it is something, well, let's say something old comparing to the family system concepts that I'm hearing all around the world that you have in USA or UK or in for what you've been talking about.
Okay. May I ask you if Ewing or John, do you want to bring a little bit of your input with what they are asking? Ewing, okay.
Yeah, sure. I think one of the questions you're asking is what is general practice, what is family medicine? And you don't know, I guess, what it means, but also what do you learn? What do you need to know to be a family medicine doctor or a GP? I think one of the things you can do is use Google and look for the college, and look, I'll give you some acronyms, but ACRRM, the Australian College of Rural Remote Medicine curriculum. So look for the ACRM or ACRM curriculum, and that'll come up very quickly with a document that defines what a rural doctor, a rural family medicine doctor, needs to know. And it lists very clearly the sort of skills and knowledge that you need to be an effective rural doctor. The other, you can Google the RACGP, the Royal Australian College of General Practitioners curriculum. And again, very quickly, you'll find it'll pop up. All that information's there, and it gives you, if you have read it, and first of all, they both talk about domains. So domains of medicine, professional domains, knowledge domains, medico-legal domains, family domains. And these curriculum statements that we have in Australia clearly define what family medicine is and what you need to know to be an effective GP. But we have to acknowledge that being a GP is being knowing many things, but knowing many things, but often not the depth that you would expect a specialist to know. But as a GP, you don't need to know everything about everything, but you need to know something about most things to be a safe doctor. Most GPs in Australia do have special interests though, so while they have a broad knowledge, they will have one area they're very interested in. For me, it's obstetrics and skin cancer. And I noticed Karini is online, and Karini spent 3 weeks with me, and apart from finding kangaroos everywhere, I think Karini certainly had an experience of what it is to be a family medicine doctor and a rural doctor. Thank you.
John, would you like to add something about? So I will just back what everybody says. So Sarine, we're talking about that you want to know more about what is family medicine, what is the family medicine specialty, and what is the difference between the other specialties, or if it is a specialty or no, and what is the residency and what we need to know. So I'm not sure if you want to say anything, John, before it. I just want to add that we also have the concept of family medicine, and in Brazil it's called family and community medicine, which means that we can act into the community as well. and work with the people into the community to change their own reality. So it's not just about be at the surgery, but about changing realities. And it's about also being a good doctor and having a range of skills in since emergency until family approach. So you need to be almost, as Ewing say, understand a bit of everything, since clinical things until very family things and family approach. So I will pass my word to John.
Thank you, Mayara. I very much agree with you and his comments there. It might be worth your while, a very simple website, the GMC, General Medical Council in the UK. Again, you can Google it, and it talks about the curriculum and being a general practitioner, and what you need to do, and what are the glossary of terms, and it takes you through the curriculum and looks at the breadth of care that you provide for your patients. I like to think that we describe ourselves as specialists in generalism. And that generalism really depends on the needs of the community that you work in. For people like Ewan, who live in very isolated and work in very isolated communities, somebody has to be an expert in obstetrics or in anesthesia. In areas like, certainly in the UK, where we don't have such huge distances, we still need skills that meet the needs of the community we live in, mental health skills, managing emergencies. So it really depends on where you live and work, but it's what I call a specialist in generalism. I think you need to have a knowledge as well about public health and about population health, because increasingly that will become part of your work. One of the other important things as a general practitioner or a family doctor is you've got to have communication skills. And those are communication skills between you and your colleagues, you and your patients as individuals, and you and your community. So you've got to understand the needs of the community, the needs of the people, and you've got to try and meet those. And that's sometimes one of the biggest challenges and one of the most exciting challenges that you have as a GP or as a family doctor. We tend in the UK to call it general practice. In parts of Europe, it's called general practice, although it's called family medicine in other parts of the world. Perhaps family medicine is a better name for it, because it gives the view that it's a specialism as opposed to just being a general practitioner. And as some of you said, that you come out of medical school and are able to work in your countries as general practitioners. But we are specialists, we have special training, and we need to work to ensure that actually that people who go into family medicine have the same training, the same level of training as people who actually go into other specialties. So I'll leave it at that, Mayara.
Right. I think this concept that we need to adapt to the community reality is very important. Also, we will like have a specialty, but depending if our community needs more has more infectious disease, so we'll be better in infectious disease. If our community is set and needs more help on surgery skills, so we have surgery skills. And then we will get more specialized on the needs of the community, but also understanding this whole need of being with the community and understanding the social determinants of health. That's something that you bring from the public health. That is, and also the difference between the public health and family medicine. The family medicine is working more and caring the people directly, and the public health will work more with the policies. So, but we need to know a lot to try to do the link between the public health and what's going on the community. So usually a rural GP or a GP or a family doctor will have a set of, will have a community, and this community will be also carried by the same doctor. So you will see the people growing, you do the postnatal care, you care the pregnant woman, and then you see the children boarding, and then you will see part of the family dying, and you'll be the doctor that will care everything, and you have the chance, I think one of the unique chance to enter in people's home and seeing their context. There is no point, I think Nisha can share a experience that she had recently. There is no point to saying to people to boiling water if they don't want to pay the gas. Can you share this story? Like, this is a very kind of family thing and primary care thing.
Yeah, so basically I work with an organization that has a lot of projects, and we take a lot of pride in going to any rural health area and just imposing what we believe in and telling them what we think is right to do for them. So I was so there was this project, and we went there and everyone was like, oh, boil some water. And then you need to boil water if you want to curb down diseases or diarrhea for your kids, etc. And then we went in again, and it was very interesting that no one spoke up, because even to have a doctor in a rural healthcare setting in Pakistan is something that they consider of as good luck, or something that they consider as something that's not really common. So we went in and they said, the problem is that you come up here again and again and tell us to boil water. We get gas for 1 hour in the whole day. In that 1 hour, either we can cook food for our kids, or we can do stuff which is very essential, or we can boil water. For that matter, yes, we love our kids, but that becomes a second priority. So you're coming up here and telling us this is not really effective. So that did make us realize how how we cannot not be there, and out of context come in and trying to impose things that are not even applicable in that very setting.
I think this summarizes a little bit about family medicine, that is also understanding the needs and trying to address it effectively, and not just as a policy, or just saying you need to eat more fruits or do that and do that, and without the context, the local context. Anyway, anyone wants to comment? Jess, Karin, Nadir, Sarin, say if you're a little bit silent.
Okay,
Yeah,
I may.
yeah.
Yeah. Firstly, hi John, I miss you. So nice to see you. I really, really miss you, okay? I just had to say this. It's so nice to see you and hear you. Okay, we have had some tweets and some comments on Facebook. Any questions, but some comments. And the last one was made from Andressa, from Univates, here from our state in Brazil, and she liked probably the phrase that family doctors have the same level of training of other specialists, and that's exactly what we were talking before. And it's really important to just as I said before, and I noticed that. Najir, sorry if I said it wrongly, but it's the same that what he said earlier as well, that it's sometimes it's difficult for people to understand the difference, especially here in Brazil, and what he said before. So I think that it's our job to keep on saying and making sure the difference between the specialty and not doing it.
Thank you.
Hey guys, are you listening to me? Yeah? Okay, so maybe Mayara froze. I think that her connection may not be okay. So we may go to our fourth question. We actually don't have one, but we can make ours. And maybe we could talk a little bit of how long does it take to do the family medicine residency in your countries, if you know that, and is it easy or not to join it? And I may start talking about this in Brazil. Here, our residency takes 2 years, and unfortunately, or not, I don't know actually, it's easy, kind of easy to enter it. Here in Brazil, if you want to be anesthesiologist, I don't know how to say this in English, sorry, anesthesiology, and to do anesthesia, it's really difficult to enter it because everyone wants to be one, because you may have lots of money with it. And here in Brazil, as we have this prejudice, is easier to enter the residency. So we have some government helps to increase the salary and to try to make people be more interested. And I hope that we're going to the right track. But by now, it's kind of easy to enter it. And I don't know if I'm saying the wrong numbers. Please, John, you may correct me if I'm saying wrongly. But I have heard that on UK, around 50% of the doctors in the UK, they are family doctors. And here in Brazil, our number is around, I don't know, 13%. So we still have lots of places to people, but they are not really interested on it. So I hope to hear from you what are your answers as well.
I think Nishwa has a question as well. Can you mention your question, Nishwa?
Yeah, sure. So my question was about what we were talking before. So I just wanted to know, what is the most effective way that public health and family medicine could overlap? Because I cannot talk, say on behalf of other countries, where in Pakistan we have very limited human resources, and especially the ones that are in rural areas. So when we talk about public health concepts like health promotion, life course, and stuff like that, what is the best way to go about public health and family medicine overlapping? So
John?
Yeah, an interesting story that when the revolution happened in Cuba, I'm told that Fidel Castro was trying to look at the most effective form of healthcare for the population, and he was of a mind very soon on that in fact it was going to be primary care and family medicine. And he sent people around the world to look at different family medicine systems. The one he liked the most at the time was the UK system, but he felt that the one problem with the UK system is that public health was not incorporated into the role of a family doctor. And so the family doctors in Cuba are actually trained in family medicine and public health as well. I'm involved in teaching global health at my medical school, and I find that medical students actually really don't enjoy the public health part of their curriculum. But if you actually use global health as a way of teaching public health, they can actually see how relevant it is and how exciting it is. So in general, and I think this is around the world, family doctors are not experts in general in public health, but perhaps we just need to look at the Cuban model because there may be some answers there.
Great. So we should check the Cuban model. And I want to ask, we have around an hour now for our Rural Café, and we have more 30 minutes around for discussion. So I just want to know if anybody have, if we are for making safe niche, Serene, dear, if you're getting a broad view of family medicine as you bring these questions, and I want to know if all of you, especially Jess, want to contribute more. Safe? Go.
Can you repeat, please, Mayara? Your question.
I just saying that we have just more 30 minutes for discussing the issue and what's family medicine. I want to know how much satisfied you are if you have a broad view of what is family medicine now, and especially for who is from Pakistan and Tunisia, that's much more something more embryonic. And then I want also know from Jess if he wants to add something on the poll. Okay. Anyone wants to?
We mentioned earlier about education required. So in the United States, I notice most of y'all talked about once you graduate, you can actually go and practice. That's not the case in the United States. You have to complete either a one-year internship, which would then make you the old term GP, which nobody does or uses anymore. Easy to get into family medicine here. They have a lot of slots for it. Our government and our insurance companies drive most of that type of competition based off what you can get into. And so you would spend 3 years in residency to become a family physician. There are some extender years that are called fellowships that are not necessarily accredited, but they might give you some additional skill sets. What is happening in the United States as far as for education for family physicians is what they're increasing proficiency in what is called ancillary services for us. So a big topic here in the past several years is teaching endoscopy work to family physicians, whether it be for screening for colon cancer for us or for esophageal cancers. Being able to do that. Now, on its surface, it sounds very altruistic that you can take in, we have a high rate of colon cancer in this country, scan individuals for these type of cancers before they become progressed. But the drive is actually for the money. So while, earlier when I talked about us having mid-level providers that are essentially taking away patients from a family physician merely because the businessmen and women in our country drive our healthcare. So it's a very different model. What happens is, if I wanted to go and set up a facility where I would be in a rural community and I would have nurses and doctors and whatnot, it would be cheaper for me to hire people like nurse practitioners and physician assistants. For my bottom line, for my profit, it would be cheaper. And so then it would be cheaper for the patients as well. Whereas family physicians are being in certain areas compared to mid-level providers. So the way we do that, the way we get around that as doctors is in our education, we start to teach them how to do things that these mid-levels usually don't do, which are things like doing endoscopy and in some areas obstetrical work, but that's kind of only in a very small area in our rural western United States. So the family physician, there are a lot of articles you can go and look. Some of the organizations here in the United States are the AAFP or the ACOFP. They put out some articles every couple of years about, is family medicine dying in the United States? And there's a lot of good suggestions that say it is. And so you see these organizations trying to change how we teach family physicians to make them relevant, because there is no discrepancy on, yes, we need them, but in our system, it is money that matters, not necessarily the health of our people. And the last thing I'll touch on is about obstetrics, because I care a lot about obstetrics. And I had at one point, been interested in family medicine. And then as I looked into it, very few family physicians are allowed to do obstetrics in the United States. So at the recent conference for the National Health Association, we have a large hospital closure issue in our country because of finding money to sustain these hospitals in areas where people need hospitals. And the number one predictor they found that determined on whether a hospital would close within a certain period of time was closure of obstetrics. So family physicians will stop practicing obstetrics for any one of the following reasons. They have poor coverage with another physician to help them manage the lifestyle required to do obstetrics and keep their practice thriving. Increased malpractice payments required by family physicians because insurance companies have decided that it is more unsafe for a family physician to do obstetrics than it is for an OBGYN to do obstetrics. So then they can't afford their insurance. The other thing is poor compensation from insurance companies to family physicians for doing obstetrics, therefore it discourages them from doing it. So when a family physician or a physician in an area at a hospital stops practicing obstetrics, a lot of times that hospital closes and leaves a large geographical area without providers and without a hospital. So those are some of the things that are happening to family physicians in the United States, that they're trying to change our education model. Whether or not they'll be successful is certainly up for debate. So it's a little bit different system. As far as public health goes, it's hit or miss. It depends on kind of where in the area you are. There's a lot of family physicians that will sit on boards of public health and will try and impact the health of their community by being, an elected official or things like that. So I hope that was useful for someone.
Thank you, Jess. I think one of the great problems is when money came before patients and communities. So people need to manage money before you manage health. But what I would like to add about family medicine is that family medicine is the backbone of the healthcare. We don't have a good healthcare if we don't have a good family medicine training and if we don't have good family physicians. So it's a bedrock of the comprehensive and compassionate and people-centered care. When we see more people and we don't people their communities and don't see just the disease. So it's really important that we overcome the disease understanding for understanding the people as a whole. So we are having a huge change on our health systems that were money oriented to try to change for more patient centered and community centered. So I think it's very important that we try to overcome the disease understanding and seeing the person as a whole and not just treating the heart or the liver. We know how to treat it, but understanding that there is hungry there is other understanding that there are cultural barriers that are different between person to person, and try to do a patient-centered approach. We have Sarin that wants to do a question, Safe that wants to do a comment, and I think John as well. John, I think you're very anxious to comment, so I will pass you, and then after I will pass to Safe and Sarin.
Okay, so sorry. I think the most important thing here, Mayra, is that if you train people properly, you make sure that they work properly. You make sure that they understand that it's a proper job. I think that the family medicine has been stained with the idea that, in fact, you can go into it without any training. And one of the examples that really impressed me is the work that's been done up in Queensland with the Rural Generalist Program. This was an area that actually had real difficulties, and Ewan knows much, much more about it than I do, but had great difficulties in attracting family doctors to go and work in some of these very isolated communities. They've set up this Rural Generalism Program, and I'm sure that Ewan can say a few words about this. But in fact, what it's been such a success that in fact the brightest students in the medical schools want to be rural generalists. And I think so. If you treat people properly, if you train people properly, they will see it as a proper job and a valuable job to do. So we have to evaluate from the very beginning. Can I just tell people, many of you will know about a professor, she's died now, at Johns Hopkins, called Barbara Starfield. And Barbara Starfield showed that, in fact, the health outcomes of a country are directly related to the quality of primary care. Now, primary care and general practice or family medicine are not necessarily synonymous, but essentially it is the major part of primary care. And I think that what we need to say is that family practice, family medicine is not just about doctors, it's about a team approach. And we need to work as a team. It's a multidisciplinary team. And probably you in Brazil have more experience about that than anything else about how teams work. But the evidence is, when it comes to outcomes and when it comes to the resources that you need, that family medicine is the most efficient and effective system of providing quality primary care. And the evidence is clear that the quality of your health outcomes are related to primary care. So this is a no-brainer. And this is why countries around the world are beginning to invest in family medicine, in primary care. And Barbara Starfield showed that it was quite clear that when she did her research into primary care, actually the one factor that mattered more than anything else was the number of doctors and the quality of the doctors. So we might worry that family medicine is under stress in certain countries, but the evidence and the research is clear. Family medicine is effective and family medicine is efficient. And that's what we want out of our health systems.
Safe?
Yeah, thank you very, very, very much, John, for your comment. I really totally agree with you. Well, and I think just to fulfill with you that investing in family medicine is investing in a successful healthcare system. But there is something that we've been talking about from the beginning, and I think that we should take in consideration is that we should not consider like family medicine and specialties or specialization medicine. So it's a kind of specialization, and this is the thing that we are working on now to make people or to make medical students more convinced that being a family doctor it's kind of specialization, but it's kind of a global specialization. It's like an engineer, a global engineer, a polyvalent engineer, and another one who is like more and more specialized in something. Here in Tunisia, we have like 3 years of residency in family medicine, and we are now setting a college of family medicine, which will supervise the goals and the training of family medicine residents. But all this process is being like it is brainstorming, and it is in the setting up. The thing that I want to add is like the family doctors and family medicine are the first connection between patients and the whole healthcare system. Like we've been talking about communication and we've been talking about successful healthcare system. It's mainly about family medicine in most of the countries, and after hearing most of the experiences now. But to succeed this approach, we need maybe to go through the community, to listen to the community and to get the needs of the community, especially when we are talking about rural medicine. So it depends on the community needs that we're going to improve kind of some parts of trainings of some family doctors. For example, we have in Tunisia, in the northwest of Tunisia, kind of some problems of hematologic problems like drepanocytosis or like these kind of problems. So I will say maybe in some places or in some kind of rural areas, maybe we need more to train family doctors on some topics or having kind of specialized or I don't know if it is the right term to use, or kind of smallly specialized family doctors that have the training like with these goals. And I think that after training the family doctors and the family residents, like the thing that we should underline is that the training should be keep up to date always. So this is what ensures the sustainability of family medicine, a successful family medicine system.
Thank you, Saif. Just to try to explain, family medicine is a specialization, but we usually say that it's a specialization in the person, in the people. So we are specialized in people. So, and their context, but it is a specialization as a whole. Yes, Saif, you can.
Yeah, just was talking about some kind of prejudices that we have here about family medicine. So these are prejudices that we want to break, and we want to move with family medicine to the other part, so that the plane can take off.
Great. Cyrene, finally.
So hi again. So basically my question is about, all of you say that the family medicine is an inspiration from the community. Like we go to the community and see what are their problems, and then we go and then we set up our goals to meet with the community problems. My question is, if there is any collaboration between family medicines and the government, since the government is installing a new system. So is there any possible ways like to meet with the community and the government, since the government, not all the governments in the world are capable of the same, are capably the same. So is that clear?
Yeah, that's great, Cyrene. I think this is a great question. Bianca, do you want to answer about local councils?
Okay. Please, Mayara, if I say something wrong, correct me. I don't know if it's the same in the UK and Australia and Tunisia, but here in Brazil, this is another interesting aspect, because here the main job that a family doctor may have is in the government places. You may work to the city hall, maybe is the name. So it's the main where that you may work, and you work to the government. I may say that, and there are lots of prejudice in this question here in Brazil, because they say that you are not recognized as a good worker by the government. But also as a family doctor, you may have a private job, because here in Brazil we have a public system, and you can also have a private service in health. I don't know if I'm saying it wrongly, but okay. And the other aspect, these two aspects about where to work and some link with the government. But there is also another link with the government that Mayara said about councils, that is that here in Brazil, our public system that we call SUS is, as I know, one of the I don't know how to say this, but I know that really few public systems in the world, they have this community participation. And here in Brazil, we have like community councils. What they are like group of people, like people who use the system, and they go together like small councils, and they have strength to say what they want, what they think that the city should have, and what changes the system should do. So people that are using the system, they may have power to change the health. So there is this link between the community and the government, because community may change the laws and may change the places where the money is going. So okay, so I think that there is these two kinds of links between family medicine and the government. The one about where you may work as a family GP, family doctor, and the link between here in Brazil, that we have the link between the community and the government, because here in our system, people and communities, they may have power to change our system. I don't know if I answered, sorry if I didn't, but I tried my best.
Nishwa, do you have a...
Yeah, so I think we're talking about how important family medicine is, and I completely agree with that. But there's another thing that I think, if we need to go about a strategic plan as to how promote family medicine in such a country where it's in its embryonic stages, like you said, for instance, in Pakistan, there are certain questions that come into mind. Firstly, there was a research that said that if you admit more people from rural areas into medical schools, there's a higher chance of them going back to their areas and working there. So to have like medical schools which are demographically equal from urban and rural areas. And secondly, that they're more comfortable, that if they have a doctor from within their community who's probably born and raised there, they're more comfortable and there's better understanding. The second thing is, the government did try to initiate something that was, because family medicine is not huge here, but they tried to incentivize general practitioners to work in rural areas by paying them more. But again, that raises a question of quality, an incentive for a material, a good, or is it more service oriented or is it more profit oriented when it comes to a doctor? And the third thing is that how do you train them? So for instance, if family medicine is something that you need to motivate people to pick up if you want, about that in medical education, and if there is someone from the city coming into a rural area to work, should there be, for instance, a minimum time for that doctor to work there, to understand, to accept, because that's what we talk about family medicine, that you need to be a part of the community to understand them and then serve them. Yeah, that's pretty much it.
Thank you, Nisha. I will try to pack in your final comment in the comment that you just did. I would like to ask for Ewing and John, that was really experienced GPs, that if they could share a bit how much they enjoy it or do not enjoy it about family medicine and what they feel. And we are getting near the end of the Rural Café. So I will ask for everybody that comment now, do the final comment, so we need to close. And I hope we did most of the things that, and maybe we can do another one about what is family medicine. We can do a second edition, and then we can keep discussing. And anyway, to keep live on Twitter and keep live on Facebook. So can I ask, I also like if you can bring a little bit of your experience and how much you enjoy it or not. Ewing, maybe first.
Thank you. Just very quickly, I've been a GP, a family doctor in my community for 28 years. I love it. My family grew up there. I care for my community and I offer a broad range of services. John mentioned the Rural Generalist Program in Queensland, which has seen some 500 young doctors move into the country. What we've done in Queensland is we've provided recognition of the importance of primary care medicine, of family medicine. We've given those doctors an identity. We've awarded those doctors with a proper pay schedule. We've also given those doctors a career path. And in Australia, we very strongly have a career path into family medicine. It's 4 years of training to become a rural doctor and a family medicine doctor. It's even a bit longer if you want to specialize as well. So it's not a year, it's much longer. And finally, we are designing and challenging fixed beliefs. So, for example, they did try and close obstetric hospitals in the country, in Australia. We demonstrated very strongly that once you close rural hospitals, babies die, mothers suffer. So we are actually reopening birthing hospitals in the country because we've got the evidence and we know that it's very safe. So you must challenge those paradigms at every step. It's very important to challenge those fixed beliefs of people with strong evidence. So the other aspect of what we do in Australia is we research, we produce data and we produce evidence of the very high quality and importance of primary care. So thank you.
Thank you. Maybe John?
Thank you, Mayara. Yeah, very quickly, I would endorse everything that Ewan has said there. Actually, the UK system and the Australian system is in many ways quite similar. Julian Tudor Hart, who some of you may have come across, probably one of the most significant family doctors, GPs in Britain, probably in Europe, probably globally, in the last century. Just two quotes from him. The first was, his quote was, "What I learnt as a medical student was no use to me when I became a doctor. And what I learnt in hospital was no use to me when I went into general practice." So it is a specialist. It's very much a specialist role. He also came up with something called the inverse care law. And that is that, unfortunately, and one of the problems of our modern societies is that most of the resources are spent on the people who need them the least. And I know that's the case in India, and I'm sure it's the same in Pakistan, that in fact, I don't know the figures for Pakistan, but I know that in India, 60% of the population have no access to basic medical care. So what we need to do is to, and it's really up to you as students and young docs, to actually start to not only speak to your patients and speak to the people, but speak to the politicians as well. There is no doubt that, in fact, family medicine is more effective, family medicine is more efficient, and family medicine will actually end in better health outcomes. WHO, please, for young docs and medical students, go and have a look at the Sustainable Development Goals that come from the United Nations. Goal 3 is about healthcare. Goal 3 also looks at the goal of having universal health coverage by the year 2030. That's only going to happen if we develop health systems in rural and isolated areas, and they will need doctors there. They will need family doctors, but they will need nurses, they will need therapists, they will need public health workers, they will need a whole range that make up the primary care team. So it's up to you guys to go out and start making a noise about it. Governments are finding themselves in a very difficult position where they're being asked to commit now to the concept of universal health coverage. And now is the opportunity to make a difference. From a personal point of view, I agree with Ewan completely. Great job, thoroughly enjoyed it, had a great life. And I just hope that I can pass that enthusiasm onto the next generation. So good luck, all of you.
Thank you, John. Now, final statements. Do you want to say anything, Bianca?
Okay, I just would like to thank you all for being here. I hope you like it. Thank you for you that are here in this conversation. Thank you for people that are watching it on YouTube. And I'm really happy. I hope you enjoyed it too. And please feel invited to the next ones. Thank you.
Cyrene?
If I want to add something, it's I think family medicine is about partnerships, partners to be partners with the community, to partner with other health care members, to partner with the government, so we can meet with all the problems that our community faces. It's not like a system that is installed from other countries. It has to be something inspired from our reality. Thank you.
Thank you, Cyrene. Jess?
I really wish in the United States we were able to kind of have this system where it's all predicated on treatment of the patient instead of worrying about your bottom line, because money drives our system, and it really does hurt our patients. That a lot of times when it comes to determining the best treatment of care, that inevitably in that conversation there's a conversation about money with the patient. When it comes to, as a physician, thinking what can I offer my patients, there's oftentimes a discussion on, is it worth my time and money to be able to do that? And it really it affects a lot of the education of doctors and family physicians here in the United States. And I hate to end on a negative note, but that's something I lament a lot, because the amount of debt we take on to become physicians drives a lot of people away from family medicine, and it is causing a problem in our system. And mentioned earlier about government, so our government's trying to stop that. There's a lot of insurance companies that prevent you from seeing a specialist unless you've been referred by a primary care individual. So we are trying to fix that, but ultimately we are a market-based system, and I don't think anyone would disagree with me saying it is definitely hurting our patients. So I've really enjoyed this talk. It's been wonderful. I love talking with people from across the world about how they're trying to deliver the best care they can to their people, because I'm an osteopathic medical student, and we believe that a person is made up of mind, body, and spirit. Notice there is no money involved in our saying mind, body, and spirit, so that's something I care a lot about. So it's been wonderful talking with everyone.
Thank you, Jess. Very strong. Karen?
So, can you hear me? Yeah. Okay. So for me, family doctor, it's a doctor who care people. So care people in all phases, care people in their all context. So for me is this, and I think it's very important. I think we need to improve the education about family medicine. A lot of students don't know how it works. A lot of students don't know good family doctors during the medicine course. And this can be a difference for improve the numbers, especially here in Brazil, for improve the numbers of people, of future doctors can be family doctors. When I spent some time in Australia, I could see that the students can spend time with good family doctors, can spend time with rural doctors, and I think we need to improve this here in Brazil and another countries around the world. So this, I think, is this, and thank you guys for this conversation.
Thank you, Karen. Nadir, any final comments?
So, I think what is lacking, especially in countries like ours, which are in transition period, that have to look at family medicine as like a failure, or because in Tunisia we have only one generation. We began the concept of family medicine in 2016, and we have only one generation of family doctor residents, and and who are so family doctor residents are those who didn't pass the exam of residency, or those who don't have the choice, or those who want to like pass 2 years then leave the country. So we don't have that generation of young doctors who is convinced with the concept of family medicine, and this is what we need to work for in collaboration with the government, the media, and the famous doctors. So in order to create that generation that are convinced of that family medicine is the future of the of the whole healthcare. Thank you.
Thank you, Nadir. Nishwa, your final comments? I think maybe Safe, Nishwa is Safe. Could you give your final comments and then we go to Nishwa?
Well, in the end, I want to thank you all for sharing these experience and sharing these ideas and comments. I'm really happy to be part of this conversation and Rural Cafe. I will say that the family medicine is the most important pillar in healthcare strategies and healthcare politics. And I will say it again that investing in family medicine is investing in a successful healthcare system and strategy. And why not? We'll set in the future a kind of an exchange, a professional exchange between family doctors or family residents all around the world, which definitely will be something like something that will enrich us and will make people know about the family medicine all around the world and know about experience, because through sharing these experience that each system is going to improve itself. Thank you, everyone.
Nishwa?
Yes, firstly, thank you very much, everyone. It was really good to be part of this conversation. And I've always loved the concept of Rural Cafe. And it was very inspirational to hear from experienced general practitioners, because we don't really have many in Pakistan who've actually, and it's very inspirational to think that they've been working 12 years or 28 years in one community. So that's very inspirational. And other than that, I think in family medicine, if we want to establish family medicine or sustainable, effective system in a country like Pakistan, it's going to take a long time. But again, I think it's in the hands of medical students, it's in the hand of governments. But I really hope that, unlike a lot of other changes that our government wanted to bring in the healthcare systems, are not only the ones that are only in policy, but they're actually ones that are strategically tailored to the needs of the country, and that whatever strategies we come up with are effective. And it's a long way to go, but again, I think there's nothing more worth it than family medicine, than a good, sustainable, effective system, which is going to help healthcare throughout the country. Thank you.
Thank you all for participating. It was a really, really, really great Rural Cafe. I just want to thank you, Univats, that were watching us on there with around 20 students in a classroom here in Brazil. They were watching the whole Rural Cafe. So I think we are like spreading. And thank you so much. The next Rural Cafe, it will be about equity in rural. It will be in 8th of July at 6 p.m. GMT. Everybody is invited, and I hope more people can join us. And I think we could like have an idea of what's family medicine and at least discuss a little bit more deeply about it. And I hope you can, everybody that were participating, neither on this YouTube live transmission or on the Facebook or Twitter, you can bring home a message of family medicine, public health, and how we can contribute and care people as a whole. So see you and keep talking